Welcome to NCLEX-ReviewPro, your trusted e-learning platform for focused, high-yield NCLEX preparation. In this session, we are diving into cardiovascular disorders and related medications through high-yield question and answer review. This is clinical reasoning training. You'll see multiple next-gen formats: highlight the text, drop-down close, matrix/grid, ordered response, and high-level select all that apply. Each one framed with full rationales and NCLEX alerts. Cardiovascular questions on the NCLEX are rarely about memorizing one fact. They test whether you understand perfusion, electrical conduction, oxygen delivery, preload and afterload, shock states, anticoagulation safety, and medication priorities. You will see rhythm interpretation, you will see heart failure management, you will see thrombolytics, you will see anticoagulants, you will see electrolyte implications, and you will absolutely see priority decisions. Throughout this review, I want you to think like this. Is the patient perfusing? Is the rhythm stable or unstable? Is this medication helping or harming? What kills first? Airway, breathing, or circulation? We are going to move through disorder management, cardiac monitoring and emergency prioritization, and then cardiovascular pharmacology and medication safety. Some questions will test pure recognition. Others will test sequencing. Many will test whether you can distinguish therapeutic effect from complication. That distinction alone separates average scores from strong scores. As you listen, do not rush to the answer. Pause. Think. Force yourself to justify your reasoning before I reveal it. That is how you build clinical judgment. By the end of this session, your understanding of cardiovascular priorities will feel sharper, faster, and more structured. Let's begin. We are starting Section 1, Acute Cardiovascular Disorders, Recognition and Management. In this section, your job is to recognize life-threatening deterioration early, connect the cues to the most likely complication, and choose interventions that stabilize the patient first. Cardiovascular questions are often really perfusion questions. When a patient suddenly deteriorates, ask yourself three things. What is happening to oxygenation? What is happening to circulation? And what intervention fixes the problem right now? Let's begin with an acute heart failure emergency that shows up on NCLEX all the time. Question 1. Here's a select, all that apply question focused on acute pulmonary edema and immediate priorities. A client with known heart failure suddenly develops severe shortness of breath. Assessment findings include a respiratory rate of 32 per minute, a heart rate of 118 per minute, an oxygen saturation of 86% on room air, audible crackles in both lung bases, and pink-tinged frothy sputum. The nurse suspects acute pulmonary edema and asks another nurse to contact the primary healthcare provider. Now the question is asking, which priority intervention should the nurse prepare to implement? Listen to the options carefully. Option A, administer supplemental oxygen. Option B, insert an indwelling urinary catheter. Option C, administer intravenous furosemide as prescribed. Option D, administer intravenous morphine sulfate as prescribed. Option E, transfer the client immediately to the coronary care unit. Option F, position the client in low Fowler's position. Take a moment and decide which interventions are priority right now. Pause and lock in your choices. The correct answers are A, B, C, and D. Now let's walk through the reasoning like an NCLEX nurse. This presentation is classic for acute pulmonary edema. The key cues are the severe dyspnea, the low oxygen saturation, crackles, and that pink frothy sputum. That is fluid in the alveoli. Gas exchange is failing, and this can become respiratory failure fast. Option A, administer supplemental oxygen, is priority because it supports oxygenation immediately. This is an airway and breathing problem first. Option B, insert an indwelling urinary catheter, is appropriate because this patient is about to receive aggressive diuresis. You need strict intake and output measurement to evaluate response and prevent worsening overload. Option C, give intravenous furosemide, is correct because it reduces intravascular volume, decreases preload, and pulls fluid off the lungs. Option D, give intravenous morphine, is included because it can reduce venous return, lower preload, and reduce anxiety and work of breathing. On NCLEX, morphine is recognized as a supportive intervention in severe pulmonary edema, especially when anxiety and respiratory distress are significant. Now let's discuss incorrect options. Option E, Transferring the client immediately to the coronary care unit is not the priority. Stabilization comes first. You do not delay airway and breathing interventions for transport. Option F, low Fowler's position, is incorrect. This patient should be positioned upright, typically high Fowler's, to maximize lung expansion and reduce venous return. Here's your NCLEX alert. Pulmonary edema equals a left-sided heart failure emergency. Your priority pattern is oxygenation support, upright positioning, rapid diuresis, and interventions that reduce preload. And always, let the ABC framework guide you. Now here's the clinical coaching point. When you see heart failure plus sudden crackles and acute dyspnea, think in terms of two immediate goals: improve oxygenation and reduce fluid overload. If an option does not help breathing or does not reduce preload, it is rarely the priority in acute pulmonary edema. That is how NCLEX wants you to think through this scenario. Alright, let's move on to the next question. Here's a bow tie, clinical judgment question focused on post-myocardial infarction deterioration. A client admitted with an acute ST elevation. Myocardial infarction begins to deteriorate 8 hours after admission. The nurse notes the following. Blood pressure is 84/52. Heart rate is 118 per minute. Extremities are cool and clammy. Urine output is 18 milliliters per hour. And there is new onset restlessness. Now we are going to complete the bow tie. First, select two assessment findings that are most concerning. Elevated heart rate, cool, clammy skin, restlessness, hypotension, decreased urine output. Next, select the most likely condition. Hypovolemic shock, cardiogenic shock, acute pulmonary embolism, pericardial tamponade. Finally, select two priority nursing actions. Initiate rapid intravenous fluid bolus. Prepare to administer vasopressor therapy. Initiate continuous cardiac rhythm monitoring. Position in high Fowler's. Prepare for immediate ambulation. Take a moment. Think through perfusion. Think through cause. And decide. Pause here if you need to. The correct cues are hypotension and decreased urine output. The most likely condition is cardiogenic shock. The priority actions are: prepare to administer vasopressor therapy and initiate continuous cardiac rhythm monitoring. Now let's reason through this step by step. 8 hours after a large myocardial infarction, the damaged left ventricle may no longer pump effectively. When cardiac output drops, blood pressure falls. When blood pressure falls, organs are underperfused. Hypotension is a direct marker of circulatory collapse. Decreased urine output, less than 30 milliliters per hour, tells you the kidneys are not receiving adequate blood flow. That is a critical perfusion indicator. Cool, clammy skin and tachycardia are also consistent with shock, but hypotension and declining renal perfusion represent the most dangerous progression. Now analyze the condition. This is not hypovolemic shock because there is no evidence of fluid loss. It is not pulmonary embolism because the scenario does not describe acute hypoxia or sudden respiratory collapse. It is not pericardial tamponade because we are not told about distended neck veins or muffled heart sounds. This is cardiogenic shock caused by pump failure after a myocardial damage. Now take action. In cardiogenic shock, the problem is not volume depletion. The problem is impaired contractility. Rapid intravenous fluids can worsen pulmonary congestion in a failing left ventricle. Instead, the nurse must anticipate vasopressor or inotropic therapy to support blood pressure and perfusion. Continuous cardiac rhythm monitoring is critical because ischemic myocardium is electrically unstable and at high risk for lethal ventricular dysrhythmias. Here's your NCLEX alert. Post-myocardial infarction, hypotension equals pump failure until proven otherwise. Cardiogenic shock follows this pattern. Low cardiac output, low blood pressure, low urine output, high dysrhythmia risk. Now here's the clinical coaching point. Whenever you see shock, classify it. Is it a volume problem? Is it a pump problem? Or is it an obstruction? Volume problems get fluids. Pump problems get vasopressors and inotropes. Obstructive causes require relieving the obstruction. After a myocardial infarction, think pump failure first. And remember, damaged myocardium is also electrically unstable. Even while treating shock, you must anticipate ventricular tachycardia or ventricular fibrillation. That is how NCLEX wants you to connect the dots. Alright, let's move on to the next question. Here's a highlight style question focused on early recognition of acute pulmonary edema after myocardial infarction. The nurse is reviewing a progress note for a client admitted with an acute myocardial infarction. Listen closely to the nurse's documentation. The client reports increasing shortness of breath. Respiratory rate is 30 per minute. Heart rate is 118 per minute. The client appears restless and anxious. The client begins coughing up frothy, pink-tinged sputum and reports a feeling of air hunger. Oxygen saturation is 88% on room air. Now the task is simple. Which finding most strongly indicates development of acute pulmonary edema? Take a moment. Scan the cues. Decide which one is most diagnostic. Pause here if you need to. The correct answer is the phrase, coughing up frothy, pink-tinged sputum. Now, let's break this down. After a myocardial infarction, the left ventricle may fail to pump effectively. When that happens, pressure backs up into the pulmonary circulation. Fluid begins to leak into the alveoli. When alveoli fill with fluid, gas exchange becomes impaired. That classic description of pink, frothy sputum represents alveolar flooding, mixed with small amounts of blood. It is not just concerning, it is diagnostic. Yes, tachycardia and tachypnea are abnormal. Yes, oxygen saturation of 88% is concerning. Yes, restlessness signals hypoxia, but none of those are specific. Pink frothy sputum directly identifies the pathophysiology of pulmonary edema. Here's your NCLEX alert. On the exam, they often hide the diagnosis inside one very specific phrase. When you see pink frothy sputum, you should immediately think pulmonary edema until proven otherwise. Do not overthink it. That phrase is a giveaway for left-sided heart failure with alveolar flooding. The exam writers want to see if you recognize the most diagnostic cue, not just the most abnormal vital sign. Now here's the clinical coaching point. When you encounter highlight questions on the exam, resist the urge to chase numbers. Vital signs can be abnormal in many conditions. Instead, ask yourself, which finding directly identifies the underlying pathology? Which phrase explains what is actually happening in the body? That is usually your answer. Pulmonary edema is not defined by anxiety or tachycardia. It is defined by fluid in the lungs, and pink frothy sputum tells you exactly that. That is how NCLEX wants you to separate specific diagnostic clues from general distress signs. Alright, let's move on to the next question. Question 4. This is a matrix-style question focused on atrial fibrillation with rapid ventricular response and its impact on cardiac output. A client develops atrial fibrillation with a ventricular rate of 150 per minute. The nurse understands that rapid atrial fibrillation can reduce cardiac output due to loss of atrial kick. For each assessment finding, determine whether it is expected or not expected with uncontrolled atrial fibrillation. Here are the findings: syncope, dizziness, palpitations, hypertension, flat neck veins. Take a moment, think about perfusion. Think about what happens when the atria are no longer contributing to ventricular filling. Pause here if you need to. The expected findings are syncope, dizziness, and palpitations. The findings that are not expected are hypertension and flat neck veins. Now let's break this down in a structured way. In atrial fibrillation with a rapid ventricular response, the ventricular rate is elevated and the atria are not contracting effectively. That means the atrial kick is lost. When atrial contraction is lost, ventricular filling decreases. When ventricular filling decreases, cardiac output drops, and when cardiac output drops, organs receive less perfusion. The brain is particularly sensitive to decreased perfusion. That is why dizziness and syncope are expected findings. Palpitations are also expected because the rhythm is irregular and often rapid, and patients feel that instability. Now let's look at the two findings that are not expected. Hypertension is not typical in uncontrolled rapid atrial fibrillation. More commonly, you see hypotension because of decreased cardiac output. Flat neck veins suggest hypovolemia or normal venous return. In low cardiac output states related to atrial fibrillation, especially if heart failure develops, you are more likely to see distended neck veins, not flat ones. Here's your NCLEX alert. When you see atrial fibrillation with a rapid rate on the exam, think perfusion. Loss of atrial kick leads to decreased ventricular filling. Decreased filling leads to reduced cardiac output. Reduced cardiac output leads to neurological symptoms and possible hypotension. On NCLEX, The question is often not about identifying atrial fibrillation itself. It is about identifying the consequences of reduced perfusion. Now here's the clinical coaching point. When you encounter a rhythm question with a rapid ventricular response, immediately ask yourself one question. Is perfusion dropping? If cardiac output is compromised, expect symptoms affecting the brain first, such as dizziness or syncope. Expect instability rather than elevated blood pressure. The exam wants you to link rhythm to hemodynamic effect. That connection separates memorization from clinical reasoning. That is how NCLEX expects you to approach uncontrolled atrial fibrillation. Alright, let's move on.
Question 5. MCQ type. This one focuses on post-vascular surgery assessment and interpretation. A client returns to the surgical unit 4 hours after an aortoiliac bypass graft procedure. During the neurovascular assessment of the affected extremity, the nurse notes warmth, redness, mild edema, and a palpable pedal pulse. Now the question is asking, how should the nurse interpret these findings? Option A. The findings are expected due to increased arterial blood flow. Option B. The extremity shows moderate impairment and the surgeon should be notified. Option C. The extremity is deteriorating and requires hourly reassessment only. Option D. Arterial flow is adequate, but venous obstruction is developing. Take a moment. Think about reperfusion. Think about what happens to a previously ischemic limb when blood flow is restored. Pause here if you need to. The correct answer is option A. The findings are expected due to increased arterial blood flow. Now, let's reason through this carefully. An aortoiliac bypass graft restores circulation to a limb that previously had reduced arterial perfusion. When blood flow returns, you often see warmth. You often see redness. You may see mild edema. Why? Because vessels that were chronically constricted now dilate. Capillary beds fill. Hydrostatic pressure shifts. That appearance can look dramatic, but dramatic does not mean dangerous. The presence of a palpable pedal pulse is the most reassuring finding here. Pulse present means arterial flow is restored. Nothing in this scenario suggests compromised perfusion. There is no pallor, no coolness, no absent pulse, no severe ischemic pain. Now, let's look briefly at why the other options are incorrect. Option B suggests moderate impairment, but there are no signs of arterial compromise. Option C implies deterioration, but these findings reflect improved circulation, not worsening. Option D mentions venous obstruction, but that would not typically present 4 hours postoperatively without additional signs such as severe swelling, cyanosis, or pain. Here's your NCLEX alert. After vascular bypass surgery, warmth, redness, and mild swelling can be normal signs of reperfusion. On the exam, the danger signs are the opposite: cool extremity, pale skin, absent pulses, severe pain. Remember that pattern. The exam will try to make improvement look alarming. Now here's the clinical coaching point. When you see a revascularization question on the exam, ask yourself one thing. Is this reperfusion or is this occlusion? Reperfusion looks warm and flushed. Occlusion looks pale and cold. If the pulse is present, arterial flow is working. Do not confuse restored circulation with deterioration. That is how NCLEX tests your ability to interpret surgical recovery correctly. All right, let's move on to the next question. Question 6. This is an ordered response question focused on post-abdominal aortic aneurysm repair and priority escalation for possible acute kidney injury. A client is 1 day post-abdominal aortic aneurysm repair. The client is receiving intravenous fluids at 150 milliliters per hour. Over the last 3 hours, urine output has decreased from 90 milliliters to 50 milliliters to 28 milliliters. Morning laboratory results show a blood urea nitrogen of 35 milligrams per deciliter and a serum creatinine of 1.8 milligrams per deciliter. The nurse recognizes signs of possible acute kidney injury. Now place the nursing actions in the order the nurse should perform them. Here are the actions. Notify the primary healthcare provider. Reassess and confirm urine output measurement. Review the current intravenous fluid rate and recent intake. Document findings in the medical record. Take a moment. Do not rush. Sequencing questions are all about safe nursing process. Pause here if you need to. The correct order is this. First, reassess and confirm the urine output measurement. Second, review the current intravenous fluid rate and recent intake. Third, notify the primary healthcare provider. Fourth, document the findings in the medical record. Now let's reason through why. When urine output drops suddenly, you do not assume the numbers are correct until you confirm them. A kinked catheter, a dependent loop, a blocked collection chamber, or a misplaced measurement can create a false alarm. So step 1 is reassessment. Confirm the Foley is patent. Confirm the output is real. Then step 2 is analysis. Review the current fluid intake and infusion rate. Assess whether there is a volume issue, a perfusion issue, or a post-operative complication affecting renal blood flow. This client is receiving a steady infusion, yet urine output continues to drop, and the labs support a real perfusion problem. A blood urea nitrogen of 35 and a creatinine of 1.8 are both elevated. Now the client is producing less than 30 milliliters per hour. That combination matters. Once you confirm and analyze, you escalate. That is step 3. Notify the primary healthcare provider, because this pattern suggests acute kidney injury and needs urgent intervention. Then, and only then, you document. Documentation is essential, but it never comes before patient assessment and urgent communication. Here's your NCLEX alert. After abdominal aortic aneurysm repair, the exam expects you to watch renal perfusion closely. A urine output less than 30 milliliters per hour is a red flag. Rising blood urea nitrogen and creatinine make it even more concerning. On NCLEX, this combination points to possible acute kidney injury. Now here's the clinical coaching point. When you see declining urine output paired with worsening kidney labs, think perfusion until proven otherwise. And on ordered response questions, follow this mental script. Validate the data, analyze the situation, escalate appropriately, then document. That is the safe nursing sequence NCLEX is looking for. All right, let's move on to the next question. Question 7. This is a multiple choice question focused on ventricular tachycardia and prioritization. A client is noted to have frequent sustained runs of ventricular tachycardia on the cardiac monitor. The client reports palpitations but remains conscious. Which aspect of this dysrhythmia is the nurse's highest priority concern? Option A. It may cause anxiety and a feeling of impending doom. Option B. It can rapidly deteriorate into ventricular fibrillation. Option C. It is difficult to convert to normal sinus rhythm. Option D. It produces increased cardiac output leading to ischemia. Take a moment. Ask yourself what the most dangerous progression is. Pause here if you need to. The correct answer is option B. It can rapidly deteriorate into ventricular fibrillation. Now, let's reason this out clearly. Ventricular tachycardia originates from an irritable focus in the ventricles. Because the ventricles are beating rapidly and inefficiently, filling time decreases. Cardiac output drops. Even though this patient is currently conscious, sustained ventricular tachycardia is unstable. The biggest danger is not anxiety. The biggest danger is not conversion difficulty. The biggest danger is not increased output. The biggest danger is deterioration into ventricular fibrillation. And ventricular fibrillation means no effective cardiac output, no perfusion, immediate cardiac arrest. That is the priority threat. Option A, anxiety and a sense of impending doom may occur, but that does not kill first. Option C, difficulty converting to sinus rhythm is not the central danger. Ventricular tachycardia can often be treated with antiarrhythmics or synchronized cardioversion. Option D is incorrect because ventricular tachycardia decreases cardiac output due to inadequate ventricular filling, not increases it. Here's your NCLEX alert. When you see ventricular tachycardia on the exam, immediately think about the deterioration chain. Ventricular tachycardia can become ventricular fibrillation. Ventricular fibrillation leads to cardiac arrest. On NCLEX, when a rhythm question asks for highest priority, it is usually asking which complication leads to immediate loss of life. Now, here's the clinical coaching point. When you read a rhythm question and see the phrase highest priority concern, stop and ask yourself one thing. What kills the patient first? With ventricular tachycardia, the danger is not just the current rhythm. It is what the rhythm can become. If a pulse is present, cardioversion may be required. If no pulse is present, defibrillation is required. That framework will show up repeatedly on the exam. That is how NCLEX expects you to prioritize ventricular tachycardia. All right, let's move on to the next question. Question 8. This is a drop-down close question focused on premature ventricular contractions and hemodynamic stability. A client is noted to have frequent premature ventricular contractions on the cardiac monitor. The nurse understands that frequent PVCs may reduce ventricular filling time and compromise cardiac output. The sentence reads, "The nurse should first assess the client's blank and blank to determine hemodynamic stability." Here are the answer options: blood pressure, serum potassium level, oxygen saturation, caffeine intake history, presence of infection, sensation of palpitations. Take a moment, think about priorities. When you see the word first, you should immediately think assessment for stability. Pause here if you need to. The correct answers are blood pressure and oxygen saturation. Now let's reason this out clearly. Frequent PVCs can shorten ventricular filling time. Shortened filling time can reduce cardiac output. When cardiac output drops, perfusion suffers. So before you investigate why the PVCs are happening, you must determine whether they are affecting circulation or oxygenation. Blood pressure tells you whether perfusion is adequate. Oxygen saturation tells you whether oxygen delivery is being maintained. Those two assessments directly relate to airway, breathing, and circulation. Now let's look at the other options. Caffeine intake may contribute to PVCs, but that is background information. It does not determine whether the patient is currently unstable. Presence of infection may be relevant in long-term evaluation, but again, not the first priority. Serum potassium level is very important for arrhythmia cause analysis. However, laboratory interpretation comes after you confirm that the client is hemodynamically stable. And palpitations are subjective. They tell you what the client feels, not whether the client is perfusing. Here's your NCLEX alert. Whenever the question says priority assessment, go straight to ABCs. Is the patient oxygenating? Is the patient perfusing? PVCs only become urgent if they compromise cardiac output. The exam is testing whether you assess stability before you chase causes. Now here's the clinical coaching point. When you see an arrhythmia question, do not immediately jump to the reason behind it. First, ask yourself one question. Is the client stable? If blood pressure and oxygenation are intact, you can move on to identifying triggers such as electrolytes or stimulants. But if perfusion is compromised, that becomes your emergency. NCLEX wants to see that you assess before you analyze. Stability first, cause second. That is safe cardiovascular reasoning. All right, let's move on to the next question. Question 9. This is a highlight-style question focused on patient teaching for variant angina. The nurse is reviewing a discharge education note for a client diagnosed with variant, also known as Prinzmetal's angina, who is starting a calcium channel blocker. Listen carefully to the client's statements. The client says, "I know I should call my cardiologist if I notice swelling in my feet or ankles. I'll also check my pulse, and if it drops below 60 beats per minute, I will notify the provider. I understand that I should avoid drinking grapefruit juice while taking this medication. Since I have angina now, my spouse and I plan to stop our daily walks at the mall. I also understand that this medication works by relaxing the coronary arteries to prevent spasms. Now the question is asking, which statement indicates a need for further teaching? Take a moment, slow down. This is a long paragraph. Scan for the one statement that contradicts the condition. Pause here if you need to. The correct highlight is the statement, "Since I have angina now, my spouse and I plan to stop our daily walks at the mall." Now let's reason through this carefully. Variant angina is caused by coronary artery spasm. It typically occurs at rest. It is not triggered by exertion or increased oxygen demand. That is the difference between stable angina and variant angina. Stable angina is demand-related. Variant angina is spasm-related. Stopping moderate exercise, such as daily walking, is not required unless specifically directed by the provider. In fact, moderate exercise is often encouraged for cardiovascular health. Now notice how the other statements are correct. Reporting swelling in the feet or ankles is appropriate because calcium channel blockers can cause peripheral edema. Monitoring the pulse and reporting bradycardia is correct. Avoiding grapefruit juice is important due to drug interaction. Understanding that the medication works by relaxing coronary arteries to prevent spasm is accurate. Only one statement contradicts the pathophysiology. Here's your NCLEX alert. On the exam, stable angina is demand-related. Variant angina occurs at rest due to spasm. NCLEX will test whether you can differentiate those two patterns. When a teaching question says, "Need further teaching," they are often testing whether the patient misunderstood the underlying mechanism. Now here's the clinical coaching point. When you see a long paragraph in a highlight question, do not rush. Do not panic. Do not assume the wrong statement will sound dramatic or dangerous. Instead, ask yourself which statement contradicts the pathophysiology of the condition. If you understand why the disease happens, you will quickly find the incorrect teaching. Exercise does not cause coronary vasospasm in variant angina. That mismatch is your clue. That is how NCLEX expects you to think through patient education questions. All right, let's move on to the next question. Let's move on to question 10. This is a select all that apply question focused on rhythm interpretation and clinical judgment. A nurse reviews a client's rhythm strip during routine rounding. The strip shows a regular rhythm with a P wave before each QRS complex. The PR interval is 0.16 seconds. The QRS duration is 0.06 seconds. The ventricular rate is 64 per minute. The client is resting comfortably and denies chest pain, dizziness, or shortness of breath. Now the question is asking, which nursing actions are appropriate at this time? Option A, continue cardiac monitoring and observe for rhythm changes. Option B, document the rhythm interpretation and assessment findings. Option C, notify the primary healthcare provider immediately. Option D, obtain laboratory studies urgently due to the rhythm strip findings. Option E, perform a quick clinical check to confirm the client remains stable and asymptomatic. Take a moment. Before choosing, identify the rhythm. Pause here if you need to. The correct answers are A, B, and E. Now let's walk through this like an NCLEX nurse. This strip describes normal sinus rhythm. There is a P wave before every QRS. The PR interval is within the normal range of 0.12 to 0.20 seconds. The QRS duration is within the normal range of 0.04 to 0.10 seconds. And the rate is between 60 and 100 beats per minute. There are no symptoms, no instability, no signs of decreased perfusion. So what is appropriate? Continue monitoring. That is standard care. Document your interpretation and your assessment. That is professional nursing practice. And perform a quick clinical check to confirm the client remains stable. Always correlate telemetry with the patient. Now let's look at the incorrect options. Notifying the provider is unnecessary because this is a normal rhythm. Obtaining urgent laboratory studies is not indicated because there is no abnormal finding requiring investigation. Here's your NCLEX alert. The exam does not just test when to escalate, it tests when not to escalate. If the strip is normal and the patient is stable, your role is confirm stability, monitor, and document. Overreacting is not critical thinking. Now here's the clinical coaching point. When reading a rhythm question, always follow this mental checklist. First ask, is it sinus? P-wave before every QRS, normal PR, normal QRS. Then ask, is the rate normal, slow, or fast? Remember this memory anchor. PR interval is 0.12 to 0.20 seconds. QRS duration is 0.04 to 0.10 seconds. Rate between 60 and 100 is normal sinus rhythm. Below 60 is sinus bradycardia. Above 100 is sinus tachycardia. But rate alone does not determine urgency. Perfusion and symptoms determine intervention. Telemetry is data. The patient is the truth. A normal strip with a stable patient requires monitoring, not panic. That is how NCLEX expects you to think when interpreting sinus rhythm. All right, let's move on to the next question. We are now moving into Section 2, question 11 to 20. Cardiac monitoring, diagnostics, and prioritization. This section is all about interpretation and stability. On the NCLEX, rhythm strips and lab values are not just recognition exercises. The real question is always, is the client stable? Can you identify deterioration early? Can you prioritize correctly? And can you avoid escalating when it is not necessary? As we go through these questions, keep asking yourself, is perfusion adequate? Is oxygenation intact? Does this require monitoring or immediate intervention? Let's get started. Question 11. This is a bow-tie clinical judgment question focused on sinus bradycardia and hemodynamic instability. A client's cardiac monitor shows sinus bradycardia. The nurse assesses the client and notes the following. The client is resting in bed. Heart rate is 45 beats per minute. Blood pressure is 82/60. The client reports dizziness. Capillary refill is 4 seconds. Urine output is 20 milliliters over the last hour. Now we will complete the bow tie. First, select 2 findings that indicate hemodynamic instability. Heart rate 45 beats per minute. Blood pressure 82/60. Regular rhythm. Complains of dizziness. PR interval 0.16 seconds. Next, select the most likely clinical condition. Stable sinus bradycardia. Symptomatic sinus bradycardia. Ventricular tachycardia. Heart block with ventricular escape rhythm. Finally, select 2 priority nursing actions. Prepare for transcutaneous pacing. Continue to monitor the client. Administer digoxin. Administer oxygen. Prepare for defibrillation. Take a moment. Focus on perfusion, not just the number. Pause here if you need to. The 2 findings that indicate instability are blood pressure 82/60 and complaints of dizziness. The most likely condition is symptomatic sinus bradycardia. The priority actions are administer oxygen and prepare for transcutaneous pacing. Now let's reason through this carefully. A heart rate of 45 is bradycardia, but NCLEX does not treat numbers. NCLEX treats perfusion. This client is hypotensive. The blood pressure of 82/60 indicates poor systemic perfusion. The client reports dizziness, which signals decreased cerebral blood flow. Urine output is low, which tells you renal perfusion is compromised. This is not stable bradycardia. This is symptomatic bradycardia. Continuing to monitor is unsafe because the patient is already unstable. Administering digoxin would worsen the bradycardia. Defibrillation is for pulseless ventricular tachycardia or ventricular fibrillation, not sinus bradycardia with a pulse. Oxygen supports tissue perfusion immediately, and transcutaneous pacing may be necessary to restore adequate heart rate and cardiac output. Here's your NCLEX alert. Bradycardia becomes an emergency only when it causes hypotension or signs of decreased perfusion. Bradycardia plus hypotension equals unstable. Do not anchor on the heart rate alone. Look at blood pressure. Look at mentation. Look at urine output. Now let's solidify this with a quick stable versus unstable summary. Stable bradycardia means the heart rate is below 60, but blood pressure is normal. The client is alert, no dizziness, no chest pain. Urine output is adequate. Perfusion is intact. In that case, you monitor and investigate the cause. Unstable or symptomatic bradycardia means the heart rate is below 60 and the client shows signs of poor perfusion, hypotension, dizziness or syncope, altered mental status, chest pain, signs of shock, decreased urine output. That changes everything. Stable equals monitor. Unstable equals oxygen, medication per protocol, and possible pacing. Now here's the clinical coaching point. When you see a rhythm question, always ask one question first. Is the patient stable? A heart rate of 45 in a healthy athlete may be completely normal. A heart rate of 45 with blood pressure 82/60 is not. On the exam, stability determines urgency. Treat perfusion, not just the number. That is exactly how NCLEX expects you to approach bradycardia scenarios. All right, let's move on to the next question. Question 12. This is an ordered response question focused on priority sequencing when the monitor shows a flat line. A client is on continuous cardiac monitoring. The monitor alarm sounds. The nurse looks at the screen and sees a flat line with no visible electrocardiogram complexes. Now, place the nurse's actions in the correct order. Here are the actions. Assess the client by checking responsiveness, breathing, and pulse. Activate the emergency response system if the client is pulseless. Document the event and actions taken. Verify the monitor leads, electrodes, and connections. Take a moment. Do not rush this. Sequencing questions are about safety and discipline. Pause here if you need to. The correct order is as follows. First, assess the client. Second, verify the monitor leads and connections. Third, activate the emergency response system if the client is pulseless. Fourth, document the event and actions taken. Now let's break this down carefully. A flat line on the monitor may represent true asystole, but it may also represent lead disconnection, loose electrodes, or equipment malfunction. You never treat the monitor first. You assess the patient. Check responsiveness. Check breathing. Check for a pulse. If the patient is pulseless, that is a cardiac arrest, and you activate the emergency response system immediately. If the patient has a pulse and appears stable, you then check the equipment. Verification of leads and connections comes after you confirm the patient's status. Documentation always follows assessment and intervention. Here's your NCLEX alert. A telemetry strip is not a diagnosis. A flat line does not automatically mean cardiac arrest. On the exam, whenever you see a sudden monitor change, assess the patient first, every time. Now here's the clinical coaching point. This is a classic safety principle. Patient first, equipment second, team activation third, documentation last. NCLEX loves to test whether you panic and call a code before confirming the patient's condition. Do not jump to activation without assessment. Assessment drives action. That is structured, safe, clinical reasoning. All right, let's move on to the next question. Question 13. This is a highlight question centered on defibrillation safety during a code situation. The nurse is assisting during a code for a client in ventricular fibrillation. After the defibrillator pads are applied to the client's chest, the nurse prepares for shock delivery. Here is the resuscitation note. Chest compressions are in progress. The defibrillator pads have been applied correctly. The nurse pauses compressions briefly. The team leader requests rhythm verification before shock delivery. Oxygen is being administered via bag valve mask. The nurse prepares to charge the defibrillator. Now, highlight the action that is the priority before delivering the shock. Take a moment. In a code, safety sequencing is everything. Pause here if needed. The correct highlight is: the team leader requests rhythm verification before shock delivery. Let's walk through this carefully. Defibrillation is unsynchronized. It is only indicated for ventricular fibrillation or pulseless ventricular tachycardia. Before you shock, you must confirm that the rhythm is still shockable. That is a safety requirement. If the rhythm has organized or changed, shocking could be inappropriate. Chest compressions continue until shock ready. Then there is a brief pause. Rhythm confirmation occurs. The team clears the patient, and then the shock is delivered. Now, notice what is not the priority at that exact moment. Intubation is not required before defibrillation. Medications such as amiodarone should not delay shock delivery. And synchronization mode is not used in ventricular fibrillation. Synchronization is for cardioversion when there is an organized rhythm. Here's your NCLEX alert. Ventricular fibrillation equals unsynchronized shock. Cardioversion equals synchronized shock. Never shock without confirming rhythm first. The exam tests this distinction constantly. Now here's the clinical coaching point. In a code scenario, sequencing equals safety. Compressions continue until the moment of analysis. Pause briefly. Confirm rhythm. Clear the patient. Deliver shock. If you reverse that order on the exam, NCLEX marks it unsafe. The question is not testing whether you know how to push the button. It is testing whether you understand safe shock protocol. That is how NCLEX expects you to think during emergency cardiac rhythm management. All right, let's move on to the next question. Question 14. This is a multiple-choice question focused on defibrillation energy settings. A client is in confirmed ventricular fibrillation. The defibrillator available on the unit is a monophasic device. The nurse prepares to deliver the first shock. Which energy setting should the nurse select? A. 50 joules, B. 120 joules, C. 200 joules, D. 360 joules. Take a moment. This is one of those questions that rewards pure exam memory. Pause here if you need to. The correct answer is D. 360 joules. Now let's reinforce why. For monophasic defibrillators, the recommended energy level for all shock attempts is 360 joules, every time. Monophasic devices deliver current in one direction only. Because of that single directional flow, a higher energy level is required to effectively depolarize the myocardium. Now let's eliminate the other options logically. 50 joules is too low. That energy level is typically used for synchronized cardioversion in certain supraventricular tachycardias. 120 joules is a common starting energy level for biphasic defibrillators. 200 joules is also commonly used for biphasic devices. Lower energy levels are associated with biphasic defibrillation or synchronized cardioversion, not monophasic defibrillation. Here's your NCLEX alert. Memorize this rule. Monophasic defibrillator equals 360 joules every time. Biphasic defibrillator equals 120 to 200 joules, depending on the device. And remember, ventricular fibrillation and pulseless ventricular tachycardia require unsynchronized shocks. Now here's the clinical coaching point. When you get an energy question on the exam, identify two things immediately. First, is this defibrillation or cardioversion? Second, is the machine monophasic or biphasic? Those two clues decide the number. Do not guess. Anchor your decision to the machine type. That is how NCLEX expects you to handle rhythm energy questions safely and confidently. All right, let's move on to the next question. Question 15. This is a drop-down close question focusing on post-Cardioversion priorities. A client has just undergone synchronized cardioversion for atrial fibrillation. The nurse begins the post-procedure assessment. The question states, the nurse's priority assessment is evaluation of the client's blank before assessing circulation or neurological status. Your options are airway patency, blood pressure, oxygen flow rate, level of consciousness, cardiac rhythm. Take a moment, think ABCs, pause here if needed. The correct answer is airway patency. Now, let's reason this out clearly. Synchronized cardioversion typically requires procedural sedation. Anytime sedation is involved, airway compromise becomes your first concern. Before you check blood pressure, before you analyze rhythm, before you assess mentation, you must ensure the airway is open and the client is breathing adequately. This follows the ABC framework: airway, breathing, circulation, then neurological status. Now, let's quickly eliminate the other choices. Blood pressure reflects circulation. Circulation comes after airway. Oxygen flow rate matters, but oxygen does not help if the airway is obstructed. Level of consciousness is part of neurological assessment, which comes after airway and breathing are secured. Cardiac rhythm is important, but it does not come before airway protection in a sedated patient. Here's your NCLEX alert. When the exam says post-procedure and priority, think ABCs automatically. If sedation is involved, airway moves to the top of your decision tree. Sedation plus electrical intervention equals protect the airway first. Now here's the clinical coaching point. Whenever you see the words after procedure, pause and ask yourself one question. Could this procedure affect the airway? If the answer is yes, that is your starting point. Airway before oxygen. Oxygen before circulation. Circulation before documentation. That simple hierarchy will protect you on NCLEX every single time. All right, let's move on to the next question. Question 16. This is a matrix question focused on priorities after implantation of an automatic implantable cardioverter defibrillator, or AICD. A client has just returned to the unit after AICD implantation. For each nursing assessment, determine whether it is an immediate priority or a secondary priority in the immediate post-procedure period. Here are the assessments. Verify device activation status and program settings. Assess cardiac rhythm and monitor for dysrhythmias. Assess the client's anxiety level. Confirm that the client has a medical alert identification plan. Assess knowledge of post-discharge physical activity restrictions. Take a moment. Think physiological stability first. Pause here if needed. Here are the correct classifications. Verifying device activation status and program settings is an immediate priority. Assessing cardiac rhythm and monitoring for dysrhythmias is also an immediate priority. Assessing the client's anxiety level is a secondary priority. Confirming a medical alert identification plan is a secondary priority. Assessing knowledge of post-discharge physical activity restrictions is also secondary. Now let's break this down. An AICD is implanted to detect and correct life-threatening ventricular dysrhythmias. If the device is not activated or programmed correctly, the client is not protected. That makes verification of activation status and program settings an immediate safety priority. Second, lead placement can irritate the myocardium. Early post-procedure dysrhythmias are possible. Continuous rhythm monitoring is essential. Those are physiologic, life-preserving concerns. Now let's look at the secondary priorities. Anxiety is important. Education about activity restrictions is important. Medical alert planning is important, but they do not override physiologic stability. Here's your NCLEX alert. After any cardiac device insertion, ask yourself 3 questions. Is the device functioning? Is the rhythm stable? Is perfusion adequate? Only after those are confirmed do you move to education and psychosocial needs. Now, here's the clinical coaching point. An AICD is not just a procedure. It is the implantation of a life-saving safety net. Your first thought should always be, is it working and is the heart stable? Education, identification bracelets, and discharge planning all matter, but survival comes first. That is how NCLEX expects you to prioritize after device implantation. All right, let's move on to the next question. Question 17. This is a higher-level rhythm interpretation question. A client recovering from dehydration has the following rhythm strip findings. Atrial rate 110 beats per minute. Ventricular rate 110 beats per minute. PR interval 0.14 seconds. QRS duration 0.08 seconds. Regular P to P and R to R intervals. Blood pressure 118/76. The client denies chest pain or dizziness. Which is the nurse's best interpretation and immediate action? A. Sinus tachycardia. Assess for underlying causes such as hypovolemia. B. Atrial fibrillation. Prepare for anticoagulation therapy. C. Sinus dysrhythmia. Continue routine monitoring without further assessment. D. Ventricular tachycardia. Prepare for immediate cardioversion. Take a moment. Read the strip systematically. Pause here if needed. The correct answer is A. Sinus tachycardia. Assess for underlying causes such as hypovolemia. Let's break this down carefully. The rhythm is regular. There is a P wave before every QRS complex. The PR interval is within normal range. The QRS is narrow and normal. The only abnormality is the rate, which is greater than 100 beats per minute. That confirms sinus tachycardia. Now look at the clinical context. The client is recovering from dehydration. Blood pressure is stable. The client denies chest pain or dizziness. There are no signs of hemodynamic compromise. This is a stable patient with a compensatory rhythm. Sinus tachycardia is usually not the primary problem. It is the body's response to something. In this case, hypovolemia from dehydration is a logical trigger. Now eliminate the distractors. Atrial fibrillation would not show regular P waves with consistent PR intervals. Sinus dysrhythmia would show irregular intervals. Ventricular tachycardia would present with wide QRS complexes and no consistent P waves. Here's your NCLEX alert. Sinus tachycardia is usually a symptom, not the disease. Do not cardiovert sinus tachycardia. Treat the underlying cause. The exam tests whether you panic at the number or think physiologically. Now here's the clinical coaching point. When you see a rhythm that is sinus and regular but fast, ask yourself one question. Why is the body compensating? Is the patient in pain? Is there fever? Is there hypovolemia? Is there anxiety? Correct the trigger, and the heart rate will follow. That is how NCLEX expects you to approach sinus tachycardia at a higher clinical level. All right, let's move on to the next question. Question 18. This is a higher-level drop-down close question focused on laboratory interpretation and anticoagulation management. A client with atrial fibrillation is receiving a continuous intravenous heparin infusion at 1,000 units per hour. The laboratory reports an activated partial thromboplastin time, or a PTT, of 60 seconds. The facility's normal aPTT reference range is 30 to 40 seconds. The nurse interprets this value as blank, and the appropriate nursing action is to blank the current heparin infusion. Your drop-down options for both blanks are subtherapeutic, therapeutic, supratherapeutic, increase, continue, decrease, hold. Take a moment. Think in multiples, not absolute numbers. Pause here if you need to. The correct answers are therapeutic and continue. Now, let's reason through this carefully. Normal aPTT is 30 to 40 seconds. When a client is receiving heparin, the therapeutic goal is approximately 1.5 to 2.5 times the normal value. If we multiply 30 to 40 by 1.5 to 2.5, we get an approximate therapeutic range of 45 to 100 seconds. An aPTT of 60 seconds falls clearly within that therapeutic range. That means the heparin is working as intended. The correct action is to continue the current infusion and continue monitoring for signs of bleeding. Now, let's clarify what would change your decision. If the aPTT were 28 seconds, that would be subtherapeutic. The client would be at risk for clot formation, and the infusion would likely need to be increased per protocol after provider notification. If the aPTT were 120 seconds, that would be supratherapeutic. The client would be at risk for bleeding, and the infusion would likely need to be decreased or held. Here's your NCLEX alert. Heparin is monitored with a PTT. Warfarin is monitored with PT/INR. Do not mix them up. Therapeutic heparin equals 1.5 to 2.5 times normal aPTT. Now here's the clinical coaching point. Do not memorize just one number. Memorize the relationship. Heparin prolongs aPTT. If it is too low, there is clot risk. If it is too high, there is bleeding risk. If it is within the therapeutic multiple, maintain the dose and monitor. That conceptual understanding will protect you on any variation of this lab question on NCLEX. All right, let's move on to the next question. Question 19. This is a matrix question focused on clinical judgment in anticoagulation bridge therapy. A client with valvular heart disease and a right atrial thrombus is receiving a continuous intravenous heparin infusion at 1,000 units per hour and warfarin 7.5 milligrams orally daily. Morning laboratory results show an aPTT of 32 seconds. The normal reference range is 30 to 40 seconds. The INR is 1.3. The therapeutic goals for this client are an aPTT between 60 and 80 seconds and an INR between 2.0 and 3.0. The institution uses a nurse-driven heparin titration protocol based on aPTT results. For each interpretation and action, determine whether it is appropriate or not appropriate. The heparin infusion is currently subtherapeutic. The warfarin is currently therapeutic. Follow the heparin titration protocol to increase the infusion rate. Discontinue the heparin infusion. Continue warfarin therapy as prescribed. Hold warfarin until the aPTT reaches therapeutic range. Take a moment. Think bridge therapy. Pause here if needed. Here are the correct classifications. The heparin infusion is currently subtherapeutic. That is appropriate. The warfarin is currently therapeutic. That is not appropriate. Following the heparin titration protocol to increase the infusion rate, appropriate. Discontinuing the heparin infusion, not appropriate. Continuing warfarin therapy as prescribed, appropriate. Holding warfarin until the aPTT reaches therapeutic range, not appropriate. Now, let's walk through the reasoning using clinical judgment. First, recognize the cues. The aPTT is 32 seconds. The goal is 60 to 80 seconds. That means heparin is subtherapeutic. The INR is 1.3. The goal is 2 to 3. That means warfarin is also subtherapeutic. Second, analyze the situation. The client is inadequately anticoagulated by both agents. With a right atrial thrombus and valvular disease, that is a high embolic risk. Third, prioritize the hypothesis. The client remains at risk for clot progression or embolization. Fourth, generate solutions. Heparin provides immediate anticoagulation. Warfarin takes several days to become therapeutic because it works by reducing vitamin K-dependent clotting factors. During bridge therapy, heparin must continue until the INR reaches the therapeutic range. Fifth, take action. Since the institution uses a nurse-driven titration protocol, the nurse should increase the heparin infusion according to that protocol. The nurse continues warfarin as prescribed. Heparin is not discontinued until the INR is therapeutic. Here's your NCLEX alert. Bridge therapy rule. Heparin equals immediate protection. Warfarin equals delayed effect. Never stop heparin until the INR is within the therapeutic range. The exam frequently tests this safety principle. Now here's the clinical coaching point. When both the aPTT and the INR are low, ask yourself one direct question. Is this patient anticoagulated right now? If the answer is no, you fix the immediate agent. In bridge therapy, that agent is heparin. Warfarin continues because it is building toward therapeutic effect. That layered thinking is exactly what NCLEX expects at a higher clinical level. All right, let's move on to the next question.
Question 20. This is a highlight question, focused on safety before initiating thrombolytic therapy. The nurse prepares to start thrombolytic therapy for a client diagnosed with an acute pulmonary embolism. Here are the assessment findings. The client is tachypnic, with a respiratory rate of 28 breaths per minute. Crackles are heard at the lung bases. The oral temperature is 99.4 degrees Fahrenheit. Blood pressure is 198 over 110 millimeters of mercury. The client reports mild anxiety. Now, highlight the finding that requires immediate provider notification before starting thrombolytic therapy. Take a moment. Think safety and contraindications. Pause here if you need to. The correct highlight is blood pressure is 198 over 110 millimeters of mercury. Let's break this down clearly. Thrombolytic therapy dissolves clots, but it also significantly increases bleeding risk. Severe uncontrolled hypertension is a major contraindication because it dramatically increases the risk of intracranial hemorrhage. Most exam references flag systolic blood pressure greater than or equal to 180 or diastolic greater than or equal to 110 as dangerous before administering thrombolytics. This client's blood pressure exceeds that threshold. That must be addressed before therapy begins. Now let's eliminate the other findings. Tachypnea is expected in pulmonary embolism. Crackles may be present and are not a contraindication. A low-grade fever of 99.4 is not prohibitive. Anxiety is common with dyspnea and does not delay therapy. Here's your NCLEX alert. Before thrombolytics, always scan for bleeding risks. Severe hypertension, recent surgery, active bleeding, history of hemorrhagic stroke. High blood pressure plus thrombolytic equals brain bleed risk. The exam will hide this contraindication in a cluster of distracting but less dangerous findings. Now here's the clinical coaching point. When a question says, report before initiating therapy, pause and ask yourself, what could make this treatment dangerous? With thrombolytics, bleeding is everything. If you see uncontrolled hypertension, that is your red flag. That is how NCLEX expects you to protect the patient in high-risk medication scenarios. All right, that completes Section 2. Next, we will move into cardiovascular pharmacology and medication safety.
We are now moving into Section 3, cardiovascular pharmacology and medication safety. This section focuses on high-risk medications, anticoagulants, antiarrhythmics, diuretics, thrombolytics. On the NCLEX, medication questions test three things. Do you know what to monitor? Do you recognize toxicity? And can you identify the most dangerous complication? Think labs. Think therapeutic ranges. Think bleeding and perfusion risk. Medication safety is precision nursing. Let's start. Question 21. This is a select all that apply question focused on warfarin discharge teaching. A client with atrial fibrillation is being discharged on warfarin therapy. The nurse evaluates the client's understanding of medication safety. Which statements indicate a need for further teaching? A. I will avoid alcohol while taking this medication. B. I can take coated aspirin if I have a headache. C. I will take my medication at the same time each day. D. If I notice bleeding gums, I will notify my provider. E. I plan to increase my intake of leafy green vegetables to stay healthy. F. I have arranged to obtain a Medic Alert bracelet. Take a moment. This is about bleeding risk and vitamin K consistency. Pause here if needed. The correct answers are B and E. These statements show need of further teaching. Let's break this down clearly. Statement B says, I can take coated aspirin if I have a headache. This is incorrect. Aspirin increases bleeding risk because it inhibits platelet function. It does not matter if it is coated. Coated does not make it safe. Unless specifically prescribed, aspirin should be avoided while taking warfarin. Statement E says, I plan to increase my intake of leafy green vegetables. Leafy greens are high in vitamin K. Vitamin K directly affects warfarin activity. Increasing vitamin K intake can lower the INR and reduce the anticoagulation effect. The key with warfarin is not elimination of vitamin K, it is consistency. Sudden increases or decreases can destabilize the INR. Now let's review why the others are correct statements. Avoiding alcohol is appropriate because alcohol increases bleeding risk and interferes with liver metabolism. Taking warfarin at the same time each day promotes stable anticoagulation levels. Reporting bleeding gums is correct, since that may indicate over-anticoagulation. Obtaining a medic alert bracelet is strongly recommended for safety in emergencies. Now here's a key exam strategy reminder. Always read the question stem carefully. Do not jump to identify statements that are correct when the question is asking you to identify statements that indicate further teaching is required. That wording completely changes your target. On the NCLEX, need further teaching means you are looking for unsafe, incorrect, or misunderstood statements. If you rush, you will pick the true statements instead of the wrong ones. Slow down. Circle the task in your mind. Are you selecting correct statements, or are you selecting incorrect ones? That discipline alone saves points. Here's your NCLEX alert. Warfarin safety rules include avoiding non-steroidal anti-inflammatory drugs and aspirin unless prescribed, avoiding alcohol, and maintaining consistent vitamin K intake. Monitor the INR. Monitor for bleeding. The exam frequently hides unsafe behaviors inside small wording differences like coated aspirin. Now here's the clinical coaching point. Warfarin questions are rarely about memorizing a dose. They test bleeding risk, drug interactions, diet consistency, and symptom reporting. When you see a warfarin question, immediately ask yourself, does this increase bleeding? Does this change vitamin K levels abruptly? If yes, that is usually your red flag. That is how NCLEX expects you to approach anticoagulation safety. All right, let's move on to the next question.
Question 22. This is a multiple choice question focused on digoxin safety and toxicity risk. A client receiving daily digoxin therapy reports anorexia. Laboratory results reveal a potassium level of 3.0 milliequivalents per liter. The provider orders a serum digoxin level. Which result would require immediate nursing intervention? A. 0.5 nanograms per milliliter. B. 0.8 nanograms per milliliter. C. 0.9 nanograms per milliliter. D. 2.2 nanograms per milliliter. Take a moment. Do not look at the digoxin level alone. Integrate the symptoms and the potassium. Pause here if you need to. The correct answer is D, 2.2 nanograms per milliliter. Now, let's reason through this clinically. The typical therapeutic range for digoxin is approximately 0.5 to 2.0 nanograms per milliliter. This client is already showing an early toxicity symptom, anorexia, and the potassium level is low. Hypokalemia increases the heart's sensitivity to digoxin, so even a level that is only slightly above the therapeutic range can become dangerous when potassium is low. A digoxin level of 2.2 is above range. Combine that with low potassium and symptoms, and you have a high-risk toxicity pattern. This is where the nurse intervenes. The immediate action is to hold digoxin and notify the provider. Because digoxin toxicity can lead to serious conduction problems and dysrhythmias, including heart block and ventricular arrhythmias. Now let's review why the other levels are not the immediate concern.
Levels of 0.5, 0.8, and 0.9 are within the therapeutic range. Even though the client's low potassium increases risk, the digoxin level itself is not elevated in those options. The exam is pushing you to recognize the dangerous combination. Symptoms plus hypokalemia plus elevated level equals intervene. Here's your NCLEX alert. Digoxin toxicity pattern is very testable. Low potassium plus gastrointestinal symptoms plus an elevated digoxin level should trigger immediate action. Do not wait for the rhythm to deteriorate. Now here's the clinical coaching point. Never interpret a digoxin level in isolation. Always look at potassium, symptoms, and the electrocardiogram. NCLEX is not testing whether you memorized one number. It is testing whether you recognize the toxicity pattern early and act safely. That is how NCLEX expects you to approach digoxin questions. All right, let's move on to the next question. Question 23. This is a matrix question focused on digoxin toxicity risk. A nurse prepares to administer digoxin to a client with heart failure and reviews the following laboratory results. Calcium, 9.8 milligrams per deciliter. Magnesium, 1.0 milliequivalents per liter. Potassium, 4.1 milliequivalents per liter. Creatinine, 0.9 milligrams per deciliter. For each laboratory value, determine whether it increases risk for digoxin toxicity or is within acceptable range with no increased risk. Take a moment. This is about electrolyte physiology and renal clearance. Pause here if needed. Here are the correct classifications. Calcium, 9.8 milligrams per deciliter, is within acceptable range. Magnesium, 1.0 milliequivalents per liter, increases risk for toxicity. Potassium, 4.1 milliequivalents per liter, is within acceptable range. Creatinine, 0.9 milligrams per deciliter, is within acceptable range. Now, let's walk through this carefully. Normal magnesium levels are approximately 1.8 to 2.6 milliequivalents per liter. This client's magnesium is 1.0, which indicates hypomagnesemia. Low magnesium increases myocardial excitability and enhances digoxin's effects on cardiac cells. That raises the risk of dysrhythmias and toxicity. Now look at potassium. The potassium level of 4.1 is within the normal range of about 3.5 to 5.0. Hypokalemia increases digoxin toxicity risk, but this client's potassium is normal. Next, calcium. The calcium level of 9.8 is within the normal range. It is hypercalcemia, not normal calcium, that increases digoxin toxicity risk. Finally, creatinine. A creatinine of 0.9 reflects normal renal function. Because digoxin is primarily cleared by the kidneys, renal impairment increases toxicity risk, but in this case, renal function appears normal. Here's your NCLEX alert. Digoxin toxicity risk increases with low potassium, low magnesium, high calcium, and renal impairment. You can remember it this way: low K, low M, G, high C, A, bad kidneys. That cluster increases toxicity risk. Now here's the clinical coaching point. Digoxin questions are medication safety questions. Before administering digoxin, quickly scan electrolytes, kidney function, and symptoms. One abnormal electrolyte can make a normally therapeutic dose dangerous. That integrated thinking is exactly what NCLEX tests. All right, let's move on to the next question. Question 24. This is a highlight question focused on recognizing a serious adverse reaction to propranolol. The nurse is monitoring a client with hypertension who recently started propranolol. Here is the nursing assessment note. The client reports mild difficulty sleeping over the past 2 nights. Blood pressure decreased from 150/80 to 138/72 after starting therapy. Resting heart rate decreased from 88 beats per minute to 72 beats per minute. During respiratory assessment, expiratory wheezes are noted bilaterally. Now highlight the finding that indicates a potential serious adverse reaction. Take a moment. Think about the mechanism of the medication. Pause here if needed. The correct highlight is expiratory wheezes are noted bilaterally. Let's break this down clearly. Propranolol is a non-selective beta blocker. It blocks beta-1 receptors in the heart, but it also blocks beta-2 receptors in the lungs. Beta-2 receptors are responsible for bronchodilation. When they are blocked, bronchoconstriction can occur. That can lead to wheezing and bronchospasm. This is especially dangerous in clients with asthma or chronic obstructive pulmonary disease. Now let's eliminate the other findings. A decrease in blood pressure is an expected therapeutic effect. A decrease in heart rate is also expected. Mild insomnia can occur with beta blockers and is not life-threatening. But bilateral expiratory wheezes signal bronchospasm. That is the serious adverse effect. Here's your NCLEX alert. Non-selective beta blockers, such as propranolol, can cause bronchospasm. Use caution in clients with asthma, chronic obstructive pulmonary disease, or reactive airway disease. When you see respiratory symptoms after starting a non-selective beta blocker, think beta-2 blockade. Now, here's the clinical coaching point. When monitoring beta blockers, think simply. Heart rate decreasing appropriately is good. Blood pressure decreasing appropriately is good. Breathing problems are not good. If respiratory compromise appears, that becomes your priority. Lungs come first if airway or breathing is threatened. That is exactly how NCLEX expects you to prioritize medication safety. All right, let's move on to the next question. Question 25. This is a multiple-choice question focused on priority monitoring during alteplase therapy. A client with ST segment elevation myocardial infarction is receiving an alteplase infusion. 30 minutes after initiation of therapy, the nurse performs a focused reassessment. Which nursing intervention is the highest priority during alteplase administration? A. Assess urine output hourly. B. Monitor for signs of internal and external bleeding. C. Assess the client's anxiety level. D. Prepare to administer heparin immediately. Take a moment. Think about the most dangerous complication of a thrombolytic. Pause here if needed. The correct answer is B. Monitor for signs of internal and external bleeding. Now let's reason through this clearly. Alteplase is a thrombolytic, also called a fibrinolytic. It dissolves clots. But when you dissolve clots, you also increase the risk of uncontrolled bleeding. The most life-threatening complication is hemorrhage. This includes intracranial hemorrhage, gastrointestinal bleeding, hematuria, and bleeding from intravenous sites or invasive lines. Neurological changes must be assessed frequently because an intracranial bleed can be catastrophic. That makes bleeding surveillance the highest priority. Now, let's eliminate the other options. Assessing urine output is important, but it is not the immediate life-threatening concern. Assessing anxiety does not address physiologic instability. Preparing to administer heparin may occur later depending on the protocol, but it is not the priority at the moment of alteplase infusion monitoring. Here's your NCLEX alert. When you see thrombolytic therapy, think hemorrhage immediately. Priority monitoring includes neurological status, blood pressure, signs of bleeding, and inspection of intravenous sites. The exam often hides subtle neurological changes as the first sign of intracranial bleeding. Now here's the clinical coaching point. With clot-busting drugs, the danger is not the clot. The danger is uncontrolled bleeding. If you remember one rule for NCLEX, thrombolytics equal hemorrhage risk. That mindset will guide you safely through any fibrinolytic question. All right, let's move on to the next question. Question 26. This is an ordered response question focused on emergency management of an anaphylactic reaction. A client receiving a continuous alteplase infusion suddenly becomes extremely anxious and reports itching. The nurse notes stridor, generalized urticaria, and hypotension. The nurse recognizes an anaphylactic reaction. Now place the following nursing actions in the correct order. Administer diphenhydramine as prescribed, stop the alteplase infusion, call the rapid response team, monitor the airway, and prepare for advanced airway support. Take a moment. This is airway and emergency sequencing. Pause here if needed. The correct order is as follows. First, stop the alteplase infusion. Second, call the rapid response team. Third, monitor the airway and prepare for advanced airway support. Fourth, administer diphenhydramine as prescribed. Now let's walk through this step by step. The client is showing classic signs of anaphylaxis. Stridor indicates upper airway narrowing. Generalized urticaria signals a systemic allergic response. Hypotension suggests distributive shock. This is life-threatening. The very first step in any severe allergic reaction is to stop the offending agent. Do not delay that step. Next, activate the emergency response system because the client is unstable and may require rapid advanced interventions. Airway protection is critical. Stridor is an airway emergency. Be prepared for potential intubation or advanced airway management. Medications such as diphenhydramine are important, but they do not come before stopping the trigger and ensuring airway safety. Here's your NCLEX alert. In anaphylaxis, remember this sequence. Stop the trigger, protect the airway, call for help, administer medications. Airway always outranks antihistamines. If you see stridor on the exam, treat it as an airway emergency. Now here's the clinical coaching point. Stridor plus hypotension equals anaphylactic shock until proven otherwise. The exam tests whether you jump to medication administration before stopping the cause. Your first move is always to stop the infusion. Sequence determines safety. And NCLEX rewards safe, structured thinking in emergency situations. All right, let's move on to the next question. Question 27. This is a select all that apply question focused on adverse effect pattern recognition with hydrochlorothiazide. The nurse is monitoring a client for adverse effects of medications. Which findings are characteristic of adverse effects of hydrochlorothiazide? The options are 1. Sulfa allergy, 2. Osteoporosis, 3. Hypokalemia, 4. Hypocalcemia, 5. Hyperglycemia, 6. Hypercalcemia. Take a moment. Think thiazide pattern. Pause here if needed. The correct answers are 1, 3, 5, and 6. Now let's reason through this clearly. Hydrochlorothiazide is a thiazide diuretic. It causes increased excretion of sodium and potassium, so hypokalemia is expected. That explains option 3. Thiazides are sulfa-based medications. Clients with a sulfa allergy are at risk for allergic reactions. That explains option 1. Thiazides can increase blood glucose levels, so hyperglycemia is also a known adverse effect. That explains option 5. Now here is a key concept. Thiazides increase calcium reabsorption in the distal tubule. That means they retain calcium, so hypercalcemia can occur. That makes option 6 correct. Now let's eliminate the incorrect options. Hypocalcemia is not expected with thiazides. That would be more consistent with loop diuretics. Osteoporosis is not an adverse effect of thiazides. In fact, because thiazides retain calcium, they may actually reduce calcium loss. Here's your NCLEX alert. Memorize the thiazide pattern. Low potassium, low sodium, high glucose, high uric acid, high calcium. You can remember it simply. Thiazides keep calcium. Now here's the clinical coaching point. The exam often tests the distinction between loop and thiazide diuretics. Loop diuretics cause calcium loss. Thiazides retain calcium. If you know that one difference, you will answer many electrolyte questions correctly. Pattern recognition is powerful on the NCLEX. All right, let's move on to the next question. Question 28. This is a drop-down close question focused on recognizing therapeutic versus adverse outcomes. A client with heart failure receives intravenous bumetanide. 30 minutes after administration, the nurse evaluates the client's response. An increase in urine output from 10 milliliters per hour to greater than 50 milliliters per hour indicates that the medication has achieved its blank effect. Your options are adverse, toxic, expected therapeutic, worsening. Take a moment. Think about the purpose of the medication. Pause here if needed. The correct answer is expected therapeutic. Now let's break this down clearly. Bumetanide is a loop diuretic. Its primary purpose is to remove excess fluid. Desired effects include increased urine output, decreased pulmonary congestion, reduced edema, and decreased preload. This client's urine output increased significantly from 10 milliliters per hour, which suggests oliguria, to over 50 milliliters per hour. That indicates effective diuresis. The drug is doing exactly what it is intended to do. Now, let's contrast that with adverse or worsening findings. Frothy pink sputum would signal pulmonary edema and worsening heart failure. A potassium drop from 3.8 to 3.1 would indicate hypokalemia, which is a side effect, not a therapeutic goal. A rising B-type natriuretic peptide would suggest worsening heart failure, not improvement. Here's your NCLEX alert. With loop diuretics, expected equals more urine. Adverse equals low potassium. Worsening heart failure equals rising BNP or pulmonary edema. Keep those patterns straight. Now here's the clinical coaching point. Whenever the question asks for expected effect, ask yourself one simple question. Did the drug accomplish its purpose? For diuretics, the mission is fluid removal. More urine means mission accomplished. That is exactly how NCLEX expects you to evaluate therapeutic response. All right, let's move on to the next question. Question 29. This is a multiple-choice question focused on safety preparedness during heparin therapy. A client with atrial fibrillation is receiving a continuous intravenous heparin infusion. The nurse reviews emergency medications available on the unit. Which medication must be immediately accessible during heparin therapy in case of serious bleeding? A. Vitamin K. B. Protamine sulfate. C. Potassium chloride. D. Aminocaproic acid. Take a moment. This is a classic antidote question. Pause here if needed. The correct answer is B. Protamine sulfate. Now let's reason through this clearly. Heparin is an anticoagulant. It prevents clot formation, but it also increases bleeding risk. If excessive bleeding or hemorrhage occurs, the specific antidote is protamine sulfate. Protamine binds directly to heparin and neutralizes its anticoagulant effect. That makes it the emergency reversal agent. Now let's eliminate the distractors. Vitamin K is the antidote for warfarin, not heparin. Potassium chloride treats hypokalemia and has nothing to do with anticoagulation reversal. Aminocaproic acid is used to reverse thrombolytic medications, not heparin. Here's your NCLEX alert. Memorize these antidote pairs. Heparin equals protamine sulfate. Warfarin equals vitamin K. Thrombolytics equal aminocaproic acid. Digoxin equals digoxin immune fab. Antidote questions are safety questions. Now here's the clinical coaching point. Anytime you administer a high-risk medication, ask yourself one simple question. If something goes wrong, what reverses this drug? That mindset reflects safe nursing practice, and that is exactly how NCLEX frames medication safety scenarios. All right, let's move on to the final question in this section. Question 30. This is our final question in the cardiovascular pharmacology section. It focuses on client teaching for nicotinic acid, also known as niacin. The nurse provides discharge teaching to a client-prescribed niacin for hyperlipidemia. Which statement by the client indicates correct understanding of the medication instructions? A. Taking this medication with meals will prevent flushing. B. I do not need to avoid alcohol while taking this medication. C. If my stools become clay-colored, that is an expected side effect. D. Taking ibuprofen 30 minutes before my dose may reduce flushing. Take a moment, think about the common side effects of niacin. Pause here if needed. The correct answer is D. Taking ibuprofen 30 minutes before my dose may reduce flushing. Let's break this down clearly. Niacin commonly causes flushing, warmth, and itching. This flushing occurs because of prostaglandin release. Taking a nonsteroidal anti-inflammatory drug, such as ibuprofen, about 30 minutes before the dose can reduce that flushing response. Now, let's eliminate the incorrect statements. Taking the medication with meals helps reduce gastrointestinal upset, but it does not prevent flushing. Alcohol should be avoided because it increases flushing and increases the risk of hepatotoxicity. Clay-colored stools are not expected. They may indicate liver dysfunction and must be reported immediately. Here's your NCLEX alert. Niacin teaching includes 4 key safety points. Flushing can be reduced with a non-steroidal anti-inflammatory drug taken before the dose. Avoid alcohol. Monitor liver function. Take the medication with meals for gastrointestinal protection. The exam often tests whether you recognize liver red flags. Clay-colored stools are not normal. Now here's the clinical coaching point. When evaluating client teaching questions, look for statements that reflect medication safety, proper side effect management, and understanding of when to report symptoms. Niacin is not a harmless vitamin supplement in this context. It is a medication with real hepatic risk. Correct understanding includes managing flushing safely and recognizing liver warning signs. That completes question 30 and concludes this cardiovascular pharmacology section. You have now worked through disorder recognition, rhythm prioritization, and medication safety. That layered thinking is exactly how NCLEX builds clinical judgment. Keep studying with intention, stay disciplined with your reasoning, and remember, at NCLEX-ReviewPro, we train you to think like a safe nurse first. You are building judgment, not just memorizing facts. So, subscribe, follow, and stick around, because we've got more Q&A sessions, mock exams, visual study guides, and voice-coached lectures coming your way. And visit NCLEXReviewPro.com to access all pro resources. Study smart, practice with purpose, and when you pass, remember, you didn't cram, you trained. See you in the next one.